I mean, one of the things I've said so many times in industry forums is you do not have a sustainable business if you're operating in an unsustainable industry. And therefore, you have an obligation to think about not just what my company is doing in this moment and how do I maximize and optimize that, but how do I make the system operate more effectively, more efficiently so that it is sustainable, so that my company can continue to be successful and not have the entire industry turned on its head at some point, which is what I think is going to happen.
Welcome to the Clearly Beneficial podcast, the show where we rip off the Band-Aid and explore the future of healthcare, benefits, and the people driving innovation in the industry.
So I am so honored today to have Paul Markovich with me. Paul is currently the Chief Executive Officer and President of Ascendiun, a nonprofit and ultimate parent of Blue Shield of California, Blue Shield Promise Health Plan, Alteus, and Stellaris. The Ascendiun family of companies is dedicated to advancing better health outcomes, improving affordability, and addressing the needs of diverse communities. Paul's also the creator of Worthy, a national movement focused on rebuilding the U.S. healthcare system to deliver greater transparency, accountability, and better outcomes for patients. Through Worthy, he is convening leaders across healthcare policy and business to drive accountable, nonpartisan solutions to put patients first. Welcome, Paul.
Thank you, Vincent. Happy to be here.
Oh, so happy to be here with you. So let's start where we want to start, and that is, back in January, what really caught my eye, you were up on the Hill testifying to Congress. Was that a specific subcommittee, or was that Congress in general?
Well, there's actually two committees, House Energy and Commerce and House Ways and Means Committee. They both have jurisdiction on healthcare. So we went back to back and did a committee hearing in first Energy and Commerce, then Ways and Means, and they lasted in total over 9 hours. We got there at like 8:30 in the morning, and we wrapped up around 7:45 p.m.
And so what caught my eye is, you're up there with, you're the Lion's Den, man. You're up there with all the CEOs of all the publicly traded health insurance companies in America. You're with Hensley. You're with them all, And there was this great little part of the testimony where one of the congressmen was saying, how many of you own an insurance company? How many of you own a bank? How many of you own a pharmacy benefit manager? How many of you own a third-party administrator? And all 5 of them were all raising their hand, yes, that we own all those. And you were the guy in the corner that didn't raise his hand at all. And I was noticeable to me, at least I caught that, Paul.
Yeah,
so what's it feel like being the guy in the room that's not raising his hand?
Well, I guess what I'd say is I think everyone I knew coming in, but I think everyone realized when I left that one of these things is not like the others. And so, I think that came out in a lot of different ways, not just in our corporate structure and the assets that we own, but our pledge to cap our profit and my willingness to say, you know what, health plans are a part of the problem. We need to take accountability for our responsibilities to make the healthcare system better and where we've not done as much as we could on that front, and who really just didn't try to play the blame game and say, well, let me tell you how it's everybody else's fault except for ours, and rather really pin it on the structure of the system and the systemic reform that's required. And finally, I think I was the only one to put together very specific, concrete proposals as to what Washington, D.C. could do to change it. So I feel like the media coverage, the response from the the members of Congress who were there, and the folks that watched me not raise my hand as you did in those situations, all concluded that one of these things is not like the others.
Yeah. And that you touch on that very briefly there, but I mean, at the end of the day, when you look at healthcare, when I look at healthcare, I mean, having been a broker for as many years as I was a broker and now doing what I'm doing today, we both have this ability of looking at this problem from 50,000 feet and trying to understand it. The problem is that everybody is so siloed in their own, in my opinion, they're all so siloed in their own little worlds that they're not looking to cross the chasm to help other people solve the problem along with them. Is that accurate?
Yeah, absolutely. I mean, one of the things I've said so many times in industry forums is you do not have a sustainable business if you're operating in an unsustainable industry. And therefore, you have an obligation to think about not just what my company is doing in this moment and how do I maximize and optimize that, but how do I make the system operate more effectively, more efficiently so that it is sustainable, so that my company can continue to be successful and not have the entire industry turned on its head at some point, which is what I think is going to happen. I think there's going to be a social political tipping point that we hit because there's so much. I mean, the cost of healthcare right now is so astronomical, continues to grow at amazing rates. Is one, not consumers, not employers, not the federal or state governments. And so something's going to have to give here. And I think that has been a fundamental problem in the industry all along, is that there's so much focus on how to make my business, my specific circumstances for my organization work, and not
Yes.
enough on how do I get the industry to function better? How do I make it a better system, therefore make it sustainably affordable and effective, in which case I've secured the long-term, it's part of the way that I secure the long-term success of the company that I'm affiliated with. And there just hasn't been enough of that going on, which is in fact why I'm now advocating for some very, very substantial structural new laws and regulations that force all the players to get out of their silos, solve problems, and figure out how to make this a much more patient-centered, high quality and affordable system.
When I look historically, I mean, I look pre-ACA and post-ACA. I mean, that's kind of the way I break up the chain, right? I think once the ACA hit, no one really, when Nancy Pelosi said, "We don't know what's in it until we pass it," people still don't know what's in it. Or if they do, all they did was they circled their own wagons tightly because they wanted to make sure they all caught their piece of the pie.
Yeah, look, I just think the Affordable Care Act is a microcosm of what you described, which is, for the most part, the players involved looked at it and figured out how to try and make their particular business successful in that.
Right.
I actually think in California, when we first started, there was actually a lot more of how do we do this together and do this well.
Right.
I know Blue Shield of California had a lot of really great dialogue with multiple providers saying, look, this is our chance. This is our chance to dramatically cut the number of uninsured, make it a win for you, make it a win for us. But if we're going to cut into that, we can help you, everyone, be profitable here, but we should think about being less profitable in this market because of its higher price sensitivity and because we want to cover as many people as possible. So if we can all just not get too carried away with how we the profit that we pursue, we can make the prices more affordable. We can create a much better market, and I think we did. And I think the success of the California exchange, especially the initial success, really highlighted that. Over time, I think we've lost sight of that as an industry. And as I said, I think it's a microcosm of everything else. If each of the players is so focused on their individual circumstances and optimizing them, then they just lose sight about how any specific decisions they make or any specific actions that they take potentially are counterproductive in the long term to their long-term business.
Yeah. I feel like, the over the years, when you're in this long enough, you get to see all the players for what they are, I guess. And where I've really been more dismayed than not in the last probably 10 years is on the provider side. And I'm not saying, small independent doctors, I'm talking about, systems and how, I hearken back to the 90s, right, where most of America did a re-engineering of the corporation. Everybody leaned down, they took out the fat, they cut the administrative costs, they did all these things. Hospitals apparently didn't get that memo. And here we are today where, listen, the job of Blue Shield and other insurance companies do, I mean, you're in essence a gatekeeper to the costs that are thrust upon you, right, by the health systems. And they keep going up unabated. So what role should hospital systems play in this conversation?
Yeah. Well, I think, to me, this goes back to why I'm advocating for structural reform in the system, because I think there's too much complaining about the way hospitals behave when in fact we've set up a system to encourage them to behave that way.
Okay.
And then feel like surprised or shocked that they are. So, I mean, if you think about it, hospitals, we want hospitals in our communities, right? We want them there in case we absolutely have serious health issue and need to use them. And they need to be open 24 hours a day, 7 days a week, available to take on patients, right, and serve them. They can't shut down the plant for a couple of weeks and, just to upgrade it. They have to be open all the time. They also have to adhere to a lot of state and federal regulations and reporting requirements and all kinds of things. So there's a really large amount of what economists and business people would call fixed costs in opening and running a hospital.
Right.
Because you have to spend huge sums of money to build it, that need to be depreciated, to keep it open, to adhere to regulations, even if there's no patients in the building whatsoever. So, and yet, in order to pay the bills and have that be able to finance that hospital, we basically ask hospitals to do as many services as possible. Get people in, keep them in the hospital, have them come to the hospital for all kinds of services that could easily be done elsewhere in a more cost-effective manner. Right. Bill and price for whatever you can. Use AI to code those claims that you sent in, the 160,000 codes that you can use to maximize your payment. And so then we turn around and say, oh my gosh, I'm so upset and angry. The hospitals are using AI to say, well, that's how they get paid. And granted, there are some abuses out there. There's literally some fraud that happens in those cases. And we've seen that as a plan from time to time. But and that should always be addressed. Any player that steps outside the lines should, that behavior should be checked. But for the most part, they're just following, they're following the carrot. They're following a way to keep their business whole. And so it doesn't make a lot of sense to me to start lambasting the hospitals over doing what we've effectively asked them to do with the payment system. Right. Whereas if we, as I propose in our Worthy segment that we released this month in June, I suggest that we should be just paying each health plan, each payer, including government programs, should be paying an annually budgeted number to a hospital for their ability to serve a catchment of population. And that should be, risk adjusted as it goes. And the payments should be higher when quality is higher and services are higher. And of course, you could monitor volumes. And if they get dramatically swing one way or the other, you can sort of make adjustments to that. But basically, if you say, you know what, hospital, you're a very valuable member of our community. We want you there for these purposes. But frankly, to make healthcare both high quality and affordable, or as we describe it, worthy of our family and friends, what we need you to do is serve as many people and as large a population as possible without having to build more hospitals. Because the thing that makes healthcare so expensive is you can just, one of the things is you just follow the capital investments of hospitals, and the bill is going to show up for decades after that.
UC Davis is building a hospital right here over my shoulder, basically.
Right, and that is going to drive some serious bills in the future. And so what we really,
the interim CEO, I was going to say, Paul, the interim CEO said the cost, when it's all said and done, is $35 million a bed.
Yes, I mean it's just crazy. And then how do you pay for it, right? And so to me, what we want to do is be able to say, you know what we're going to do? We're going to pay you irrespective of whether people have come to the hospital or not. And we're going to pay you if you help keep people healthy if when you serve them, you do it in a high quality fashion and with a high level of service. And so now the incentive structure is, well, how do I serve a larger and larger population without having to make huge capital investments? I'm only going to make those capital investments if they're really, really necessary. And my economic model as a hospital turns into, how do I get into primary care and prevention? How do I get the things that don't belong in the hospital? Like, we become tertiary and quaternary centers. We put, ambulatory surgeries in ambulatory surgery centers, and we don't want to be doing colonoscopies here. We'd rather have you do an at-home fit test for your screen if you're not an above average risk. And so the whole mentality changes as a hospital, and the hospitals start thinking about how, as you said, they didn't get the memo on efficiency. They have to think about how to get more efficient as well as deliver high quality care. And as a result, we slow down, like, large construction projects, huge capital investments, which are just going to keep driving these prices up higher and higher and higher, because the hospitals are just going to creatively and persistently look for ways to bill for what they're spending.
I absolutely. And so, that's a good lead into the next sort of question is, so you've created what you're calling a movement, right? Worthy. And so when did that hit you?
Yeah.
What was the kind of the genesis of that? And, where does that go? I mean, I want to understand your rationale behind it. I saw you did a launch event with Mark Cuban in New York, all these things. And so I'm stalking you, Paul. I just watch this stuff on LinkedIn,
Oh, I appreciate it. Yeah.
But at the end of the day, you got Mark Cuban throwing stuff at the wall 28 times a day on LinkedIn. It's mind blowing. But that said, tell me about Worthy. And I've read all the stuff myself. I've got my brain around it a bit, but for the audience and for the listeners, tell us more about that.
Well, everything for us starts with our nonprofit mission, which we describe as, we're here to create a healthcare system that's worthy of our family and friends and sustainably affordable for everyone. I sometimes just shorten that to worthy of us. And as we looked at it, we realized that what that means is that if one of your loved ones needs to access the healthcare system, first of all, you want them to be able to afford it. Not just the insurance premiums to get coverage, but any of the out-of-pocket costs associated with their care. And then you want them to be treated the way you would expect your loved ones to be treated at their time of greatest need. That's the standard. And that should happen for everyone, not because you and I happen to know people and we can make calls and work around the system, but the system works like that for everyone all the time. We realize that we are a long ways away from that ambition when we put that out there, and there was really no way to get there without structural systemic reforms. You couldn't incrementally improve an irretrievably flawed system and get to that ambition. And so we've been working on that, and I can give you a list of things we've done. I'm really proud of. I'm proud of the progress that we've made. But what we realized is that in order to really make this shift, we needed the cooperation of others in the healthcare system. So, like, for example, we can't unilaterally just decide to pay hospitals the way I just described we should pay hospitals. We need the hospitals to agree and come along for the ride.
It's really funny because I would argue that Medicare pays them what they want to pay them, and there you go.
Yes, and we are not Medicare. So it's a very different dynamic, as you might imagine. We could, and you've lived it, and you know why. I'm happy to describe that to your listeners if you'd like. But so what we found is that our ability to make progress against that vision and all the things that need to change has been limited by how quickly other players are willing to come along. And we, it's not infrequent for us as a Blue Shield of California or the Ascendiun family of companies to encounter, well, that's interesting the way you want to do things, but nobody else is asking me to do things that way, right? And so we're almost always the first ones out of the gate trying to move to something else and convince someone to say, let's move to this way of doing it, and then let's make this the standard going forward, as opposed to, I'm doing something special and custom and, for you. So So what we found over the years is that we just can't get to a truly affordable product and meet that worthy of us standard on our own. We need help. And so worthy was this idea that we need help, particularly from Washington, D.C., from elected officials. We need to pass a series of laws and reforms and regulations that force the industry to get out of their silos, as you described it, to lean in, to change the way we pay everybody so that we're paying for better, more affordable care. Better, if we pay for better health, we will get better health. Right now, we pay for more healthcare treatment and we get more healthcare treatment. So changing the payment system, creating a digital health record for every American, making pharmaceuticals affordable, putting the entire system on a budget, and tying healthcare cost inflation to levels that are at or below wage inflation. All of these things are examples of the types of reforms that we think need to happen. And so worthy is our attempt to lay out these types of reforms, explain them, and hopefully garner some support for them, create a platform and a dialogue, and hopefully a group that can advocate for those reforms and help actually make something happen in Washington that will ultimately lead to the vision I described at the beginning, which is a healthcare system worthy of us all.
Well, I mean, I think that, it's where it starts. I mean, I think legislators need to be educated well. And I've sat in those meetings over the years, on whether in California or even in DC, where you're with a legislator or a staffer who are just asking you the most basic questions about healthcare, how healthcare works.
Yeah.
And, they don't have a clue, and so how do you move that needle? And not only with them, but actually with the systems themselves, because one of the things that you brought to mind there was, about maybe 6-8 months ago, I was talking to someone at a large health insurance company, and they started talking about the California Office of Healthcare Affordability, this thing that exists that is trying to cap hospital cost increases at like under 4% a year by 2030-ish. And apparently the insurance industry loves it, but the hospitals are suing to make it go away. So how do you blend this, rather than a instinct, what can we do to help? It's the instinct of what can we do to protect our own fiefdom?
Yeah.
Right?
Yeah. Well, you know what? I don't think there's any way to avoid that in my experience, because there's the instincts and the habits are so deeply woven into so many in the industry to just say that I have a responsibility to try and protect and preserve that which we've created to this point, that it's unavoidable. There's no way you're going to drive the change that we need to drive in the system and have everybody be comfortable with it. We're going to have to make folks uncomfortable. And I think the California Office of Affordability is a brilliant example of that. And in the way I think about it now, because I have, to be honest, no sympathy for the hospitals on this question. And I'll tell you why. It's when you look at the facts, which I've laid out in the same worthy segment I mentioned to you, hospital revenues over a 20-year period have grown by almost 2.5-fold, from a little under $600 million a year to 1.5 trillion. And that is compounded, I think, more than an 8% growth every year for 20 years.
Yeah.
And so they are the hospitals are the largest cost for all of health insurance by far right now. So the hospitals do not have, on the macro, there are some hospitals in rural areas or those that are serving almost exclusively or predominantly Medicaid and uninsured populations that truly have a revenue problem. So there is a small number of hospitals for whom that's true. But for most that get most of the money, they do not have a revenue problem. They have a cost problem.
No, absolutely. I agree with that.
Yeah. And all the Office of Affordability is suggesting here is that hospitals, as well as everyone else in the industry, in the healthcare industry, does what every American and California family has to do every year, which is figure out how to make ends meet with a modest increase, which is around 3%. And so, and that is not even saying, you know, these massive increases in revenue you've had for the last 20 years, we're not even going to ask you to bring that down. We're just the rate of increase going forward needs to be modest, like the wage increases for everyone else. And the response is, we're going to sue? I mean, so I guess what I'd say is, I think this is, you know, exhibit one, Vincent, that the hospitals have not got the memo. And what I will say is that this is the hospital association. I have spoken to a number of different hospital leaders. They are not all in the same camp on this. The same way when you look at the Office of Affordability, when it started, all the health plans weren't in the same camp. And that's true of, you know, a lot of these things. So I don't want to paint them all with that brush, but clearly their organization, their trade association is probably reflective of the majority. And that's why I don't have a whole lot of sympathy. It's like, look, you have an accountability. We all have an accountability to make healthcare affordable for everyone. And it's an incredibly modest ask to say, you know, figure out how to make do the way every American and California family has to make do every year.
Right. That's absolutely correct. So let's talk a little bit about Blue Shield of California, of whom I am now a happy member with a Medicare Part G plan. Actually, I sold Blue Shield my whole career, and this is the first time I'm actually a member. So this is great. But you guys, a couple of years back, in fact, I remember hearing first of it when I saw you in Palm Springs, whenever it was 3, 4 years ago, whenever that was, and meeting with your team there, the changes you intentionally made around purchasing drugs on behalf of your members, the pharmacy benefit manager solution and change. How does that work out for Blue Shield?
So far, so good. You know, I'm not, knock on wood. We launched the effort in January of 2025, and we haven't yet, but we plan soon to release the numbers. But our pharmacy trends have probably been about 3 percentage points below, or even more, the national average for 2025, which is roughly what we were. It's actually a little more than we were projecting in terms of savings from the program. It's over $100 million where that represents that difference. So, and there's really 3 pieces to it, I'd say. The first piece is was to just effectively do all the administration that a pharmacy benefit manager would otherwise do. So if you're not going to use a pharmacy benefit manager, you still need to figure out how to get drugs home delivered and figure out how to get all the data feeds in and do all the regulatory filings that are required. Just to name a couple of examples, and to do that effectively and efficiently and serve customers well. And then, you know, the second piece was to negotiate directly with pharmacy manufacturers and get to a direct deal with a net price. So get out of this ridiculous opaque world where it's like, well, the list price is some huge number, inflated number, and then if you sell enough of the drug, your actual price is much lower. But what we'll do is send you this huge sum of rebates through your pharmacy benefit manager back to you, or a set of fees through a group purchasing organization and through a specialty pharmacy. There's just, the whole system is awash in massive amounts of cash. And in one of the worthy segments, we talked about the fact that Humira, which is the most expensive drug that Blue Shield of California paid for in 2024, its list price was nearly $7,000 a month the last time I took a look at it. But the actual revenue that AbbVie was collecting for it was a little over $2,000. So there's like almost $5,000 of rebates and fees and everything going through all these intermediaries. So what we want to do is to say, no, if it's $2,100, we'll just pay you that and be done.
Right.
And by the way, also eliminate the incentive to prescribe or fill the most expensive drug because it's profitable, which is the way the system is today. Right. So number one was get the administration right. Number two was get some direct deals with pharma, which we always knew was going to be a multi-year process. And number three was to change the way we paid physicians and hospitals so that we eliminated their incentive to prescribe or administer certain drugs. Because right now, there's hospitals, one of their most profitable parts of their business is to bill the health plans way higher amounts than the drugs actually cost them, including through a federal program called 340B.
Yeah, I've heard a lot about that lately. Is it true that these days, the hospital, like you mentioned AI earlier, the patient goes in, the doctor turns their scribe on, they have a conversation, and all of a sudden that simple visit now becomes a triple complex visit, and now they're sending those claims over to you. Your AI is now looking at those claims and going, we're not going to pay that. And so now it's a battle of the AI. Is that a semi-accurate statement?
I think it's accurate statement. I mean, that is happening for sure. And, it's one of the big things that's driven the increase in trend over the last several years is that I think the health plans are catching up to what hospitals and some physicians are doing. But at Blue Shield of California, we noticed that we even had we've had situations where almost every patient, in one case for 18 months, every patient at a hospital was coded as being septic. But they weren't actually necessarily being treated for being septic, or folks were being coded as having excessive bleeding, but they weren't being treated for what you'd expect excessive bleeding. Like you would expect someone who had excessive bleeding, at least in some cases, to get a blood transfusion.
Right.
And so what we were seeing is all these things where it's like, well, if you say anywhere in there I find infection, then I code for the highest grade of infection. Right. If I see anything in there that says you've been bleeding, I code for the highest level of bleeding. So that has clearly been going on, and all of the health plans are now trying to figure out how to push back on that using their own tools. And so, yes, that's absolutely what's going on. It also is a reminder as to why we need to change the payment model, because as I've told everybody, it's like, yeah, let's just say our health plan AI fights this to a stalemate. I mean, the hospitals and the physicians, they have every incentive in the world to figure out the next way. There's 160,000 codes that the hospital to submit claims, and not all of them impact the payment, but a number of them do. There's going to be the next thing that comes up, and playing whack-a-mole against very strong financial self-interest is not a recipe for success. It's also why we need federal reforms, I think, something like the Office of Affordability to drive the change, because right now it's been so lucrative. Who would want to change the payment model and effectively take a capped payment each year? It's like, no, I feel really good about what we're doing here. I feel like all these revenue cycle management things we're doing are going to make me a lot more money. So why would I voluntarily sign up for this thing? So it's a challenge that requires, I think, this federal and sometimes state governments to intercede to force the structural changes that need to happen. Because as I said, I just don't see the industry doing it itself. And this is a great example of it, when it's so lucrative to use AI to just enhance your coding. It's going to happen.
Yeah. So speaking of structural changes, I keep seeing this conversation keep popping up. It's not going away, and it's the Medicare for all conversation.
Yes.
Anytime people start, going down a rabbit hole of something, that's the go-to, answer to everything. And now the irony, of course, is now that I'm on Medicare, right? It's the best health plan I've ever been on, Paul. Honestly, I mean, between that and my supplement, I mean, come on, better than anything I've ever sold a client, anything I've ever been on myself. And so, what is your take on the Medicare for all as a solution?
Yeah, well, I think the first thing, Vincent, we need to do is actually define what it is. I mean, because right now it's a bit of a bumper sticker slogan. And so,
absolutely.
Yeah. And so, like, for example, Bernie Sanders and some of his colleagues introduced a Medicare for all bill a number of years ago. And that particular bill would have been an absolute disaster. For a whole host of reasons. Like, for example, it just doubled down on fee for service and gave coverage of almost 100%. It didn't do anything to address the digital infrastructure, the incentives, pharmacy bills, like the things that I'm talking about here that would.
Yeah.
So you would have had just complete runaway inflation that couldn't possibly be afforded by the country and wasn't holding anyone accountable for the quality of the care or the service that they were providing.
Right.
Now, that's not to say that someone couldn't come up with a Medicare for all proposal that is actually affordable, that actually could potentially improve the system. So I believe the things that we believe in, we're putting out there with Worthy. And I happen to agree with Atul Gawande, who wrote about on this a number of years ago, which is to say that I feel like healthcare is so fundamental to everybody that you want to be messing with it as little as possible. So whatever system you happen to be on, you want to make only the changes that are necessary to make in order to sort of optimize the performance of that system. Because if you try to turn the United States into, say, the United Kingdom, it's such a massive transformation that all kinds of things would go wrong. But then again, the same thing, if you were in the United Kingdom and you wanted to turn it into the United States, that's a bad idea. And you're messing with people's health and their lives. And so someone could come up with some kind of Medicare for all proposal that could make sense and potentially could get support from the private sector. Because if you think about Medicare for all right now, more than half the beneficiaries are getting their Medicare through a private health plan. And so, you could interpret Medicare for all to be all kinds of things.
Right.
There could be someone who comes forward with a proposal that makes a lot of sense but it could be described under that rubric.
Yeah.
The things that I have seen so far in the Medicare for all don't address the fundamental issues with the healthcare system. They don't change the payment methods. They don't hold the healthcare providers and others accountable for the quality of their service and their care.
Yeah.
It doesn't address pharmaceutical pricing and how to make that affordable and manageable. And so anyone who comes up with a solution, whether it's Medicare for all or something else, you can put forward something that addresses those fundamental drivers, or it's just not going to work. And I would say the one comprehensive bill that has been put out there for Medicare for all that I have seen was Bernie Sanders' bill from a number of years ago, and it did not meet that test. That's not to say, again, Vincent, that somebody couldn't come up with something that's actually worthy of our attention and debate.
Yeah, no, absolutely. Absolutely. So look at let's put that aside because I want to wrap up here. Assuming we keep going down the paths we're going down today, what does this look like in 5 years?
Well, what I hope it looks like is that all or most of the reforms that we're proposing on Worthy are adopted, and we've moved the industry onto a completely different trajectory from a cost standpoint and also from an accountability for quality and service. That would be my hope. My fear is that if that doesn't happen, we're going to hit some social political tipping point where a populist group, a bipartisan populist solution comes out that could be ruinous, unintentionally ruinous to not just to the industry, but to, more importantly, to people's lives and the healthcare system that we have. Because look, we don't have the capacity to be particularly thoughtful in times of crisis. And so, and we are on the brink of, if not at the beginning of, an absolute crisis, especially when it comes to the affordability of healthcare in this country. And we're going to have to deal with it. And so I think if we don't pass some thoughtful structural reforms, eventually folks are going to say, we've had enough of this. Here's what we're going to do. What that looks like, I don't know. A conservative version of it might be you get to negotiate all of your prices, health plans, hospitals, and physicians with Donald Trump, and he's going to tell you what your prices are. If it's a more, it might be some version of Medicare for all and outlawing private insurance altogether. I mean, there's all kinds of flavors. I don't know what ultimately looks like, Vincent, but those kind of very heavy-handed solutions are the kinds of things that I think we might face if we don't start taking the affordability crisis we're facing seriously.
I hear you there, Paul. I mean, I think you're spot on with all that. So, all right, now to a lighter topic. I mean, I remember when we sat down together for dinner in Palm Springs. I know you were on your way to Spain, I think, at that point. This was a couple of years back. I seem to recall you also have a predilection toward wine. And so give me your fave region, fave wine, fave whatever, favorite grape. What tell me something about that.
Well, first of all, my wife and I we see wine as a food, and so the same way like you might like maple syrup, you wouldn't necessarily want maple syrup on your spaghetti, right? And your tomato sauce. I mean, it just doesn't pair quite well. Similarly with wine, you really want to have the wine kind of match the food that you're eating. So whatever my favorite grape varietal is happens to be, well, what are we having for dinner? And how do you match up the wine with what you're eating? The same way it's like, I don't have maple syrup every time. I really love good maple syrup, but I don't have it with everything I eat.
Right.
That depends. But what I will say is that one of our, when I look at the California wineries, probably our two favorites are Aperture and Opus One. Aperture's in Healdsburg.
Jesse Katz, yep.
Was named winemaker of the year by Wine Enthusiast last year.
Yep.
He's like in his early 40s and is just.
I mean, he ran Screaming Eagle. He was the winemaker for Screaming Eagle back in the day.
And he makes all kinds of wines and different grape varietals, including a brilliant Malbec, and there's very little Malbec that's grown domestic here. Everything he touches basically turns to gold, as far as I'm concerned. And so, and they've got a wonderful wine tasting room. Opus One has quite a reputation. I think it's well earned, and so it's expensive without a doubt, but it's it's very, very good. And so those two, and that's of course in Oakville in Napa County.
Well, I appreciate the CEO of Blue Shield of California repping California. So that was good.
Well, we've spent a lot of time in California. There's a lot of other wonderful wineries out there, but I'd say those two rise to the top for me.
Excellent. Well, Paul, this has been a pleasure, absolute pleasure to have you. Thank you for sharing your thoughts about, all the things. And I look forward to staying in touch with you and continuing the conversation.
Oh, my pleasure, Vincent. Thank you so much for having me.
Okay, great. This podcast reflects the personal views of the host and guests, not their employers or sponsors. See you next time.